welcome everyone. And it is a great pleasure to be filling the shoes of Bilal today. And I get to have a go at hosting our fantastic Pearls lecture series. This is the 10th lecture that we've had this year, and all the content's available to view online on YouTube. Just quickly, a bit about Pearls. It started last year in August. Pearls stands for Focus for Emergency and Acute Care in Resource Limited Settings. Myself and the team went over to Vanuatu to do some ultrasound training for the emergency doctors. It's been really successful, and we continue to review their images afterwards, obtained with handheld ultrasound. The course has been replicated in Tonga and is about to be run in Papua New Guinea, including with a ICU component, partnering with our ICU colleagues here in Australasia. Today, we're really honored to be lectured to, well, not lectured to, he's quite a nice guy. Mike Schick will be speaking to us about the pediatric abdomen. A little bit about Mike. He is a well-known name in the ultrasound community. He hails from, most recently, UC Davis, but it's been fantastic that he's traveled down under with his family, moving to New Zealand. And he's a great source of knowledge, and really happy that he'll be able to share some of that with us today. Mike is really notable for having published the Ultrasound in Resource Limited Settings, a case-based open access text, which is an innovative online platform where really eye-popping cases can be shared and we can all learn from. Mike, tell us a bit about yourself and what made you take the trek down under, and what brought you into this global ultrasound interest.
Yeah, happy to. Thanks for having me. Really happy to be here and talk about pediatric abdomen. Well, I've always been interested in global health and delivering care and building health systems in low resource settings. And then I ended up doing a fellowship of ultrasound after my emergency training. And so I ended up often being tagged as the ultrasound person in a lot of these programs I was getting involved with. And I became ultrasound director for global emergency care in Uganda, and then this other program in the Gambia, and in other programs in Southeast Asia and Central America. And that led to research projects in low resource settings, and eventually textbooks, one of which you've highlighted there. So I found, a passion for point of care ultrasound, and especially its use in low resource settings. I think that's probably where it's most effective and most useful. And anyone that's done any work in that type of setting, I think, attests to the same thing. So it's one of the things I like most about my job, and I like to continue doing it now in the area that we live. And so I'm hoping to work in places that you have all worked or are currently working. I came to New Zealand with my family and my wife and 3 kids because we're just looking for a change, a new adventure, a better work-life balance, a place that's safe and beautiful, and that we can sort of give our children that sort of international experience. And so that's why we're here.
I love it. And bonus points for spruiking my home country of New Zealand. Well done. Don't mention anything about the Rugby World Cup though, please. That's still a bit sore. All right. Well, take it away, Mike. And for everyone watching, save your questions for the end. At the end of Mike's lecture, we will stop the recording and we'll have a nice casual Q&A session. Alrighty, take it away, Mike.
Sure thing. So I've gone ahead and I'm going to give this talk, which I gave at Sonic, which was an ultrasound conference in the south of New Zealand. And it's on the pediatric abdomen, point of care ultrasound emergencies. It's basically supposed to be about 20 or 25-minute talk. And then at the end, I have a few additional cases that I'll go over as well. And I'm really happy to answer any questions. I'd say that this talk is more directed at a resource setting that's like New Zealand and Australia, because that's where the talk was given. But I know that some of you may work in lower resource settings, and perhaps you may not have ready availability to CT scan, for example. So I think after the lecture, it's a great opportunity to talk about, well, what would you do if you didn't have CT available? You know, what would be the next step? Because I think there is a next step, and you have to adapt a lot of this research to your clinical setting. And that's what I really enjoy talking about. So we can get into that. I don't have any disclosures to make. And the objectives of this talk are really to talk about the major cases where point of care ultrasound is very useful in the diagnosis of the pediatric abdomen and or the vomiting child. Often those two things go together. And we're going to talk a little bit about the literature, but not everything, so we don't have that much time. I'm going to include a lot of the benefits and limitations of ultrasound in each of the major cases of abdominal pain in the pediatric patient. We're not going to talk about some things that you would get from a typical adult abdominal pain lecture, like biliary disease, urinary obstruction, things like that, or bowel obstruction, because we're just talking more specific pediatric cases. And I'll talk a little bit about technique, how to do the scan, or maybe just some pearls, but not a comprehensive instruction on how to do the exams, because that would be a whole sort of separate lecture. And also just note that a lot of the cases that I'm presenting, the cases are not supposed to be mysterious, not supposed to be challenging cases. These are very typical cases in pediatric emergency care. It's more about the use of ultrasound and kind of what to do next that I think is the interesting part here. So the first case is the case of the pediatric road traffic accident. And you see this everywhere in the world. A 5-year-old male presents after being involved in a road traffic accident. He was on the unrestrained rear passenger. He appears well, has stable vital signs. He's crying, found to have tenderness palpation along the right lateral chest and abdomen. And the driver has significant traumatic injuries. So this is an ultrasound lecture. So of course, ultrasound is going to be part of your diagnostic workup. And for the patient that's had perhaps some type of blunt trauma, what you're going to do is the pediatric or the FAST exam. So focused assessment of sonography and trauma. And this is just one view. We're not going to go over all the views, but this is just a typical view in a pediatric patient. And if you've done a few of these, you can see that this is the left upper quadrant of the abdomen. And this would be the spleen of the patient, the kidney, the diaphragm would be here, spine is here. And typical places you're looking for free fluid would be kind of around the spleen, kind of lower pole and the upper pole, not between the spleen and the kidney, because they have the splenorenal ligament there. It's a notable difference between the left and right sides of the abdomen. And you're looking for free fluid above the diaphragm in the chest as well. Now, I said this is a typical scan you would see in a pediatric patient because this scan is normal. There's no free fluid. And this is most often what we'll find when we do the FAST exam in a pediatric patient. So the pediatric FAST exam, the first question you should ask yourself is the pediatric FAST exam the same as the adult FAST exam? And this would be very uninteresting if it was exactly the same, and it's in fact very different. So we have come to rely on the FAST exam in adult patients. It's quite sensitive for picking up hemoperitoneum and blunt trauma patients. Now, the main difference in pediatric patients is that pediatric patients, they have larger solid organs. They get multi-organ injuries quite commonly with blunt trauma, but they less commonly get hemoperitoneum. And therefore, the FAST exam in pediatric patients is not positive at the same rate as adult patients. And that is a real challenge when it comes to the pediatric FAST. And you have to know the numbers and then use it accordingly. So we'll go over a little bit of the literature, just some summaries here. And you don't need to read this or memorize it, but I'm just going to summarize a few of these for you. So Medicare in 2014, they did this secondary analysis looking at a lot of patients, over 6,000. And they were just trying to see what clinicians did with the FAST exam, how they used it with different pediatric patients coming in with blunt trauma. And they just found that there was a lot of bias. So if the clinician thought that it was a high likelihood that the patient had significant abdominal trauma. They would do a lot of fast exams to try to prove that there was some significant injury. Whereas if they felt that the patient did not have significant injury, very low likelihood, they would use the fast exam to try to avoid doing CT scan. And that can be problematic when your fast exam has a low sensitivity, as it does in pediatric patients. Jim Holmes et al., who's a colleague of mine from UC Davis, did a lot of research in this area and had a excellent randomized controlled trial where he looked at, well, does the pediatric fast exam make any difference? Does it lead to diagnoses, to reduce CT scans, to changes to cost or hospitalization? And he found that it made no difference to any of those. But please keep in mind that he was only looking at hemodynamically stable patients. Kornblith did a retrospective review, 354 patients, and was looking at, well, is the fast exam and physical exam, are those independent factors when looking at significant blunt trauma, abdominal trauma, and just found that the pooled sensitivity of them combined was much greater than them alone. So individually they're significant, but combined they have a much greater sensitivity, which to me tells me there is a role for the fast exam, even if the sensitivity is lower than in adult patients. Ling et al. Did an important study where they did a nice systematic review meta-analysis of 8 different studies. And one of those studies was that Holmes study that we have here in the chart. And they were all prospective studies that they included. And they found that the pooled sensitivity of the fast exam for pediatric patients was just 35%. So that, I think, number is really critical, knowing that, well, if you have a low likelihood of pediatric blunt trauma, you do the fast exam and it's negative, there is still a chance that the patient has significant trauma and you're going to miss it on the fast exam. Long et al. Was finally a retrospective study. I looked at hemodynamically unstable patients. And there's a lot of numbers to include, but basically, if the pediatric patient had a positive fast exam, there's a very high likelihood that they need some sort of surgical intervention. It's just almost always, vast majority of the time, more than 60%, more than 70% of the time, it was a significant injury that required intervention. So if you have a positive fast, those patients need at least CT scans or some other path if CT is unavailable. So I want to summarize all this once more, because I know that's a lot of information to throw at you. So the pediatric fast exam, to summarize, it can identify injuries the physical exam can miss, so it can be important. Combining the exam, your physical exam, with the fast is better than physical exam alone. The fast may be incorporated into a screening algorithm with history and exam and other tests to reduce the use of CT, but it has to be done with caution, because the sensitivity of the fast exam in stable pediatric patients is much lower compared to adults. So a negative fast does not rule out an intra-abdominal injury. A positive fast is an indication for a CT imaging. So that was case number 1, and happy to answer questions at the end. All right, case number 2 is the child with fever and abdominal pain. It's a 10-year-old female presented for 2 days of worsening tummy pain and decreased appetite. Found to have a mild fever, tachycardia, otherwise appears well, and tenderness of palpation in the lower abdomen. So not supposed to be a mystery diagnosis. Like I said, this is the ultrasound. After you ask the patient, where's the pain? You put the probe on. You're using a linear probe, as you can see here. And you found this sort of tubular structure that looks edematous, perhaps dilated, and has very hyperemic color flow here, sometimes described as a ring of fire. Other structures just in the area that you might notice is you have intra-abdominal muscle here, psoas muscle here, and this is probably the peritoneal line right here. So we're talking about appendicitis. And these are just my tips to find the appendix, because this can be quite challenging, especially if the appendix is normal or if it's retrocecal, which the majority can be retrocecal. You first try to just go where the patient has pain. If they can't tell you exactly where that's at, then you go to the right lower quadrant. You're looking for the psoas muscle, that rectus abdominal muscle, and the iliac vessels. And we're in a transverse plane here. And you can see bowel kind of going right over those iliac vessels. And you're looking for this blind-ended tube that is extending from the cecum. And it rarely looks this good, but you're looking for a blind-ended tube. In a normal appendix, it'll peristalse, you can compress it, but in an abnormal appendix, it'll be dilated, there might be fluid around it, might have an appendical lift. And it's usually more than 6 or 7 millimeters in diameter. So the ultrasound in pediatric patients is pretty good. The sensitivity is somewhere between 71 and 99%, and the specificity is excellent. So ultrasound is the way to go. This is typically what we do for our pediatric patients. But I don't know if you've ever done this as a clinician. It can be really challenging. So these are the sensitivity and specificity if you're like a pediatric sonographer. If you're not a pediatric sonographer, your sensitivity is going to be much lower. And so you need to practice a lot to get good at it. And so what do you do when you can't visualize the appendix? So even if you have a pediatric sonographer do this test, they will miss 25 to 73% of cases. So like half of cases, they're not going to be able to see the appendix. And if you're doing the scan, it might be more than 50%. So kind of what's the next step? The next step is, are there secondary signs of appendicitis? Now, I generally don't look for these myself. I have, but I would prefer a sonographer, like someone who does a lot of these, or it might be a radiologist in your setting, to do this pediatric scan and look for secondary signs. So if I've looked myself and I can't find the appendix, I'm going to try to get like an official ultrasound or a radiology ultrasound done so they can really evaluate for secondary signs. But if I had no one else, then I would do this myself. And the secondary signs you're looking for are appendical lifts, free fluid, usually in the right lower quadrant is between the bowel, echogenic inflammatory changes of the bowel. So if you have a patient has right lower quadrant pain, you cannot find the appendix, and they have no secondary signs, so no fluid, no appendical lift, no inflammatory changes, then the negative predictive value is really, really good. And this is for patients that have low Alvarado scores. So that means that they're low risk, lower probability for appendicitis. And this was actually really significant for me, because I would have all these cases all the time where they couldn't find the appendix, but to have no secondary signs is very reassuring. And a lot of these patients can be watched at home to see if their symptoms get better or worse. If they have an elevated white blood cell count, or their Alvarado score is a little bit higher for any reason, the negative predictive value is still good, 90%, if they have no secondary signs. If it's higher than that, then you would consider maybe watching these patients in the hospital. If they have secondary signs of appendicitis, so there's some free fluid there in the right lower quadrant, then the odds ratio, 6.5 times higher, they have an appendicitis rate 10 times that they would otherwise. So these are high-risk patients that need surgical evaluation and need to be watched in the hospital, or maybe get further imaging. All right, so that's appendicitis. Next case is the vomiting newborn. So 1-week-old newborn presents for poor feeding. The child was fussy, now appears very fatigued. Was born at 30 weeks gestational age, spent 1 week in the neonatal ICU, formula fed. Abdomen appears mildly distended. So you do an ultrasound, and this is what you would see, or this is what you might see, the vomiting infant. So all the kind of risk factors are there. It's not supposed to be mysterious, right? So it's a high risk infant. They're premature. We're in the NICU. So what you might see here is this is a loop of bowel. This loop of bowel looks very abnormal. It's very dilated. The wall is extremely thick. It has all this echogenic material within the bowel lumen. And you might be thinking it in your head, but that echogenic material is air within the lumen of the bowel. Additionally, there is some free fluid here and here adjacent to the bowel. If you were to scan the infant's liver, you might see this. Again, here you have echogenic lines kind of running throughout the liver here. It's really prominent right in this area. So you might describe this as portovenous air within the liver. Often people say, well, pneumobilia, in this case, is portovenous air, but often they're kind of like, people will get those confused or use those interchangeably, even though they're not the same vessels. And then you might also see this in these patients. So this is within the abdomen again. What we're seeing here is that there's air that's sort of just creeping right at the very top here, where the peritoneum is. And it's creating these A lines. It's obliterating the rest of the ultrasound image, as air likes to do. We call this the curtain sign sometimes, when air sort of swoops in and just destroys our image. And this is a sign of pneumoperitoneum. So these are all the ultrasound signs, or some of the ultrasound signs of necrotizing enterocolitis, or NEC. So a very significant, dangerous diagnosis that you often see in premature infants, although they don't have to be premature to have this diagnosis. And it can be a tricky diagnosis to make. Ultrasound, turns out, is not the best way to do this alone. So if you're going to do this, it's a lot of work. You have to sweep the entire abdomen with the ultrasound, often going in two planes. You have to look at whether the bowel is thick or thin, whether there's peristalsis present or absent, whether there's intraluminal air, free fluid, or free air throughout the entire abdomen. If you do all of that, the sensitivity is only between 27 and 48%, depending on the study you're looking at. The problem is the tests we often use, which are plain radiographs, the sensitivity is also really bad, 50 to 60%. And this is a really significant diagnosis. The good news, if you want to call it good news, is that there is value in doing a radiograph and an ultrasound, because the pooled sensitivity is greater than doing one of the modalities alone. So sensitivity gets close to 80% if you can do both. This is one retrospective study that looked at 54 equivocal X-rays of necrotizing enterocolitis, and they did ultrasounds, and 22 out of that 54, they found intraluminal air with the ultrasound, which just tells me that there's value in adding ultrasound to this. Our next case is a 2-year-old with abdominal pain. Episodic pain that increases in frequency. The child pulls her legs up into her chest during these painful episodes. Has vomiting, no fever or diarrhea. Vital signs are normal, and the abdominal exam is normal. You do an ultrasound, and this is the right upper quadrant of the patient, just kind of below where the liver is. I know just based on the description and the age of the child, you know the diagnosis, and what you're seeing here is a lumen of bowel kind of stuck within another lumen of bowel, giving you that sort of sandwich sign or pseudo kidney sign. There's a lot of names for it. And this is, of course, intussusception. Intussusception, the diagnosis is usually made by ultrasound. It's really an ideal modality to use with this diagnosis. The sensitivity and specificity are excellent. The majority of these ileocholic intussusceptions, which are the ones we care about, are in the right upper quadrant. Most of the other ones are in the right lower quadrant, but usually scan the whole abdomen and checking for intussusception, but also signs of obstruction or free fluid. So here's another view of a transverse intussusception where you can see the sort of intraluminal and extraluminal portions of the bowel. It really has that pseudo kidney appearance on this scan. And this is where I just would like to remind you to use graded compression with your abdominal exams. Really, the abdominal exam with ultrasound is not complete unless you've really used sequential compression. So a little bit of pressure and then more and more to really move intraluminal air out of the way, to move bowel out of the way, to check for peristalsis, to check for pathology like this. So you really need to do that during your exam. All right, next case is the infant with vomiting. So this is a 4-week-old female. It presents for vomiting after feedings. It's projectile and non-bilous emesis. Vital signs are normal and the abdominal exam is normal. Do an ultrasound and this is what you would find. We're in the epigastric region of the patient. Point out the structures here. We have the liver. Here you can see that there's some dilated, fluid-filled, content-filled loop of bowel, and this thick-looking thing here. Just one more view of this. Now you can see kidney, liver, again, very fluid-filled, which is stomach, and then again, very thickened portion here, which is the pylorus. So this is pyloric stenosis. Relatively common diagnosis and very easy to make with ultrasound. Just going back to the clip real quick. Because the stomach just gets filled up with liquid, it's so easy to find and highlights the pylorus really, really well. So as long as you have this sort of right angle with the ultrasound, you get the stomach in view, that's a really easy diagnosis to make. Ultrasound is the perfect modality to make this diagnosis. And you're going to have to freeze the image and make some measurements because you want to know if you have to do surgery or not. Of course, the clinical picture is the most important, but what you're looking for is greater than 3 millimeters of muscle thickness, greater than 50 millimeters of length of the pylorus, or greater than 11 meters of diameter. The next case is the infant with vomiting. Not our first infant with vomiting. This is a 10-month-old female that presents for 1 day of bilous emesis, fussiness. Exam shows mild tachypnea, dehydration, and normal abdominal exam. So you do an ultrasound, and this is what you would find. And here we are in the sort of mid-abdomen epigastric region, sort of scanning down to the mid-abdomen, I should say, and we're in the transverse plane. Just to point out some structures, you can see that looks like a dilated loop of bowel here. You can see kidney coming in and out of view here. Let's see, right there. The spine is in this region. You can see the shadow of the spine. And then I'm going to pull your eye to this part right here, where it almost looks like there's a twisting or swirling of contents there. And what that is, it's vessels mixed with mesentery. Just take another look at it, but with color flow this time, just so you can really follow that swirling that we would often describe as a whirlpool sign. And you can really follow that color flow as well. So you might have guessed this is a midgut volvulus. Now, ultrasound is also really an ideal modality to make this diagnosis. I think it's really underutilized. Sensitivity is really good, as well as specificity. We used to do a lot of upper GI series in these patients, but you can see that the sensitivity is not as good. So the technique for this is you want to identify the superior mesenteric artery. And if you've done any point of care ultrasound for AAA's, abdominal aortic aneurysms, you can definitely identify the superior mesenteric artery. So if you identify it in the transverse plane, you just follow the vessels and you slide caudate. And if there's no swirling of the vessels with the mesentery, then you rule out the diagnosis. This is another patient, but similar, same diagnosis. But if you just follow the blood vessel here, so superior mesenteric artery, you can see how it's taken up and it just starts swirling around. I'll try to do a better job pointing out with my mouse when it plays again here. But you have the shadow of the spine. You have the aorta. It's giving off to superior mesenteric artery right here. And if you follow that artery into the mesentery here, you can see it just spin around and give us that classic whirlpool sign. All right, so that's midgut volvulus. So that's the end of this portion, but I do have 4 other cases that are also very quick that I just wanted to share with you as well. I'm just going to switch to another lecture here. You'll have to forgive me that I'm going to really quickly go through other cases that have nothing to do with the pediatric abdomen. A lot of them are related to echocardiography or pulmonary pathology and are very interesting, but we'd have to do them at another time. All right, so here's one more case here. So this was, we're just going to say these are all children, although these cases could be adult cases as well. But 3 days of right upper quadrant pain, epigastric discomfort, fever and chills. This was someone who immigrated from Vietnam many years ago and just visited there again to see family. And right upper quadrant pain and fever. So of course I'm going to do a right upper quadrant ultrasound. And the first thing I'm going to look at is the gallbladder. Always looking for gallstones. So here's the gallbladder here coming in and out of view, a long view of it. Liver here, get a little view of the kidney as well. And then you can see the portal triad in this area, that typical Mickey Mouse sign, portal vein, common biliary duct and hepatic artery. And no gallstones to speak of. No, there's no wall thickness of the gallbladders, no pericholecystic fluid. So I just scan the liver a little bit more and start to get a little hint of some abnormality here. You know, the echo texture of the liver should all be quite uniform. And instead you have this sort of hypoechoic mess of something right here and very irregular borders. Try to get another view of it. Now it looks a little bit more circumscribed. And so I'm thinking about mass or abscess or cyst. And of course, the patient has a fever, so abscess is really top of my list. I was in a location where I could get a CT scan of the patient, and there was actually 2 of these within the patient. And you can see from the description of the CT scan that the thing that they were concerned about the most was an amoebic typhlitis with liver abscess. And after drainage of these, the diagnosis was confirmed to be an amoebic abscess. And so the patient, before we confirmed the diagnosis, was started on antibiotics, which included metronidazole, which would be the most important antibiotic for an amoebic abscess, and then went on to get interventional radiology drainage. And this is just another patient. This one's from Africa, where they had a liver abscess as well, or amoebic abscess here. All right, we're going to skip through this case. All right, case number 7. So this case is from an adult patient, but I've seen plenty of pediatric patients of the same thing. So this was a 69-year-old female with history of hypertension, presented to the emergency department with malaise, right upper quadrant pain, nausea. It was intermittent for 2 months and worsened over the last 3 days. She recently immigrated from Argentina. She reported an unintentional 20-pound weight loss over the past year, denied any past surgical history. So I know a lot of things come to mind, especially with that weight loss. Physical exam, sorry about the Fahrenheit there, but she has a little bit of a fever. that's like probably like 38.2, something like that. A little tachycardic, otherwise the vital signs look okay. She's tachycardic on exam, abdomen soft, non-distended, but there's tenderness in the right upper quadrant and hepatomegaly. And the ultrasound produced this still image. I think I have one more. I'll go to CT. So the ultrasound is really ideal for making these diagnoses. As you'll see on the CT, it's not as good of an image on the CT scan. This is a very classic image of the diagnosis, which you may know already, but I'll reveal it in a moment. But you can see it's a well-circumscribed structure. It has a little thin wall to it. It's within the liver. It has lots of cystic portions on the inside and some solid portions as well. On CT scan, you can really get a sense of the size of it, but you don't really get a sense of all the other cystic parts and things like that you really see on ultrasound. You can see how sizable this is for the patient, and you can imagine how they would have lots of symptoms. So the diagnosis, this is an Echinococcus granulosus hydatid cyst. And these are often perpetuated in the feces of dogs and sheep as the intermediate host, and then somehow they get into our food supply and humans can ingest them, and they can go anywhere in the body pretty much. Most commonly, they present in the liver, then the lung, but they can be in the brain and the intestines and bones and other places too. So the management, you want to get some serologic testing, but you start them all on albendazole, some anti-parasitic medication to treat the infection. And then if you really need to drain some of these because they're very symptomatic or they're compressing something, then you may drain them, but you have to be very cautious because the contents of these can cause anaphylactic reactions if they get spilled into the intra-abdominal cavity. All right, moving on to case number 8. This is in picture of Uganda, just on a road, moving from hospital to hospital. This was an 8-year-old that had fever, abdominal pain, and constipation. So this male was living in Uganda, presented with his family for 3 days of high-grade fever, had constipation and severe abdominal pain. His abdominal pain was poorly localized, it was constant and progressive. His family reported mild subjective fevers and abdominal cramping the week prior. No trauma, ingestions, or anyone else who was sick. No other medical history or surgical history. These were his vital signs. So he was a little hypotensive and tachycardic, tachypnic, and febrile. And he appeared very ill. He appeared toxic. And his abdominal exam was concerning. It was diffusely tender and had guarding. I only have still images from this scan. It's a real patient. But you can see with the arrow sign here pointing out that some very diligent scanning did show that there was some free fluid in his abdomen. It wasn't just here, but that's one place we demonstrated it. Here at the tip of the liver, it says, ignore the letters where it says left upper quadrant. This is the right upper quadrant of the patient. That's the tip of the liver. And you can see that there's additional free fluid there as well. And this wasn't the only place that had a normal looking bowel, but this was one particular loop of bowel that looked quite dilated. So you can see we're measuring it at 4.49 centimeters. And at least I believe this is small bowel because I think I can see some plicae circularis there in the middle. And that shouldn't be more than 3 centimeters, and it's 4.5. The bowel wall also looks very thickened, and that normal bowel wall should not be thicker than 3 millimeters. Here we're measuring the bowel wall. The bowel wall measurement is not really perfect. It's not really kind of straight where I would like to measure it. But if I did measure it perfectly, I think it'd be even thicker than what they got. And you can see that we're at 0.69 centimeters and should be less than 3. So we're in a very low resource setting here in Uganda. We did a rapid malaria test, which is negative, rapid HIV test, cultures were sent, and kind of limited in other tests that we can do. So we start fluids and antibiotics, and the only thing we can really do there's no CT scan. We consult the surgery team and send them to the operating theater. And he got a laparotomy. The patient was found to have a 1 centimeter perforation, 2 centimeters from the proximal cecum. Gross stool contamination within the peritoneum, way more than you would have expected based on the ultrasound. And I think this is something that's sort of typical of kids, pediatric patients. You see a little bit of free fluid, you're probably going to find a lot more. The perforation was repaired primarily, and the peritoneum was irrigated and then closed. The patient completed a week of intravenous antibiotics and was discharged in stable condition. So he did really well. The final diagnosis, he had typhoid. So he had typhoid fever. It caused intestinal thickening and inflammation, and eventually perforation. All right, and then this will be the last case. That is sort of an abdominal case. This is that's a waterfall in Laos where I did some work. And this is a 65-year-old, but we'll talk about a pediatric patient as well. This is a 65-year-old female with lower abdominal pain that worsened over 2 weeks, fever and chills at home. And they have a lot of medical problems, which includes end-stage renal disease, and they're on hemodialysis. That's what those letters mean. Diabetes and hypertension. They have an AV fistula, and they have tenderness in the right lower quadrant of the abdomen. This is the ultrasound of the right lower quadrant of the abdomen. So with the linear probe, so you know what I care about is superficial. And I can't really use my mouse when I'm presenting here, but just going from top to bottom, you have the sort of epidermis, the hypodermis, you have intra-abdominal or rectus muscle there. Right below that, you have this big hypoechoic, almost anechoic fluid collection is what that is. And then below that, you have the peritoneum with the intestine. Here it is with 2 still images sort of put together so you can get a better idea of the extent of it. And now you can really appreciate that there's muscle above and below this collection. So it's like an intra-abdominal fluid collection. Here we're trying to measure it. It's pretty good size. This is an example of a different patient with the same diagnosis. So you have, I can use my pointer with the videos here. So you have a femur that shadows. This is a quadriceps muscle with all this sort of hypoechoic, anechoic material within the muscle. So the diagnosis for this patient, they have pyomyositis. They have an infection, inflammation, and fluid collection within the muscle. So we see this in both high resource and low resource settings, and the presentations are often quite different. In high resource settings, if we're in New Zealand or Australia or the United States, they're often older patients that have immune compromised states, they're on dialysis, they sort of get intravascularly stressed quite commonly, and that leads to bacteria that can see different parts of the body, which includes the muscles, and they will have polymicrobial infections within their muscle. You have to treat them with very broad spectrum antibiotics that covers gram-negative bacteria. Now, in low resource settings, you often see pyomyositis, and it's really common to see it in children, and it's very common in tropical areas. So it's called tropical pyomyositis sometimes, and the etiology of it is not 100% well understood. I saw a lot of it in Lao, and I think that at least some of it is because when a child had a fever, maybe just an upper respiratory infection, they would go to the pharmacy, and the pharmacy often just gave the parent a needle to give their own child an intramuscular injection of some medication. And I'm not sure how they were, administering that, if they're doing it cleanly, sterilely, and it seemed to lead to a lot of pyomyositis, and it would be many different places. This was a child in Lao, and this really sort of picture on the top is their calf muscle, and then the two videos are a short axis view of their calf, or gastrocnemius, and this is a long view of their gastrocnemius. And you can just get a sense, I think, that the area within the muscle is very hypoechoic, the sort of anechoic portion right in the middle, that is very abnormal. Muscle typically looks really uniform. It looks like steak usually, right, with very sort of regular striations of the muscle. And so this child had pyomyositis, and this is another child who had pyomyositis of their hamstring muscle. You can kind of see this anechoic portion within their muscle. And these infections are typically just regular gram-positive bacteria. So all these children would respond really well to what we would consider very normal antibiotics, the penicillins, amoxicillins, and things like that. All right. So that brings us to about 50 minutes of time, and that's about